Welcome to Breast Cancer Breakthroughs. What if you could get a glimpse of what's happening with your breast cancer with just a simple blood test? A liquid biopsy is just that, a blood test that can detect circulating tumor DNA, or ctDNA, which are pieces of DNA from cancer cells that are released into the bloodstream. It can also detect tumor cells that may be floating in the bloodstream. Researchers are investigating how ctDNA can be used to predict things like recurrence, treatment response, resistance to treatment, and more. In this episode of Breast Cancer Breakthroughs, we speak with Dr. Daniel F and Dr. Erin Cobain as they explain what ctDNA is and how it's poised to someday revolutionize breast cancer care. We also spoke with Dr. Seth Wander to discuss the SERENA-6 trial, a trial recently presented at the annual ASCO, or American Society of Clinical Oncology, conference. And this trial tested how ctDNA could be used to monitor treatment resistance in metastatic breast cancer. Like many new tools and techniques, the use of liquid biopsy and ctDNA has traversed more than one field of study. When we asked Dr. Hayes to describe liquid biopsy and ctDNA, he talked a bit about its history.
Really, the term liquid biopsy was coined about 15 years ago to mean any test one could do in a blood sample, or for that matter, a urine sample, but not necessarily a tissue sample, that would give us the same results as what we might get if we did a tissue biopsy. So I'm assuming most of the people on this call have had breast cancer, and you've probably had a needle biopsy and then maybe even the whole tumor excised. And your doctors probably did a variety of tests on those, most importantly, including the estrogen receptor, the progesterone receptor, and HER2, but other things too. So that's a real tissue biopsy. We began to recognize decades ago, 40 years ago, that maybe we could get information out of a blood test, which is much easier to do than a tissue biopsy, and also that we could do serially. So tissue biopsy, we can do 2 or 3 tissue biopsies in a row, but most patients begin to say, that's enough, I don't want you to stick the needles in me anymore. But most people don't mind the blood test. And then about a decade ago, there was a really landmark paper published in the New England Journal of Medicine out of Cambridge, England, that showed that we could do the same thing with cancer that the obstetricians had already figured out how to do with pregnant mothers. And that is, there is DNA from our cells floating around our blood all the time. And the obstetricians would use that to see if there is something wrong with the fetus in an expected mother. The people at Cambridge figured out they could do this by looking at not normal DNA, which we always have in our blood all the time, but looking at mutated DNA, which they proposed had to come from a cancer. And so they looked at a bunch of patients who had metastatic breast cancer. And sure enough, they found what we now call circulating cell-free tumor DNA.
You can learn more about liquid biopsies in the video linked below. While Dr. Hayes introduced us to ctDNA, Dr. Erin Cobain provided specific examples on how it is implemented in clinical practice.
So I would say that I routinely use circulating tumor DNA tests to help determine most appropriate therapy for my patients that have metastatic or stage 4 breast cancer. And I'll give you an example that I think is quite common in breast cancer practice, which is that for patients that have a hormone receptor positive, HER2 negative metastatic breast cancer, their initial treatment that they often receive is usually some form of anti-estrogen therapy, and then another drug called a CDK4/6 inhibitor. These drugs have now been in use for many years and have dramatically improved outcomes for our patients. But at some point, the cancer usually does learn how to grow or spread to other places in the body, despite that initial therapy. And the treatment that we give as often the second line of therapy is usually very much determined by the molecular profile of the tumor cells. So another example is that patients with metastatic hormone receptor positive, HER2 negative breast cancer often have mutations in a gene called PI3 kinase in the tumor cells. There are now 2 FDA-approved drugs for individuals with this disease that have PI3 kinase mutations. They are alpelisib, which is a PI3 kinase inhibitor, and capivasertib, which is an AKT inhibitor. And so routinely, when patients have initial progression of their cancer on that very first treatment that I prescribe for stage 4 breast cancer, if circulating tumor DNA is able to identify an activating PI3 kinase mutation in the tumor cells, I then would use either alpelisib or capivasertib, or perhaps even enroll that patient on a clinical trial of a novel PI3 kinase inhibitor in combination, usually with a different form of anti-estrogen therapy, as their next treatment. So this is now really a tumor biomarker, again, associated with a therapy, FDA approved, and oftentimes much easier to identify that PI3 kinase mutation through a liquid biopsy or ctDNA test than it would be maybe to repeat a tumor biopsy, as Dr. Hayes was referencing earlier.
One way that we've heard that researchers are harnessing the power of ctDNA is by using it to monitor for treatment resistance. One trial taking this approach is the phase 3 SERENA-6 trial. This trial, focused on those with metastatic estrogen receptor positive HER2 negative breast cancer, is testing whether switching treatments when a specific mutation is detected in the blood versus when the cancer progresses on a scan, and seeing if this can improve outcomes for patients. While this approach has been used in other types of cancer, this is the first large-scale trial in breast cancer to use ctDNA to inform switching treatments during the first line of therapy. The first results from this trial were recently presented at the 2025 ASCO annual meeting. Dr. Wander told us more about this trial and what the results could mean for patients.
So these are patients who have metastatic hormone receptor positive HER2 negative breast cancer who were just relatively recently diagnosed and are on their first line therapy. So that's the aromatase inhibitor with a CDK inhibitor. The concept here is that mutations can arise in the gene that encodes the estrogen receptor. This is called ESR1. If you look at breast cancer patients who have just been diagnosed, either in the early stage setting or in the metastatic setting, and they haven't received a lot of prior therapy, the frequency of mutations in that gene that encodes the estrogen receptor is extremely low, probably on the order of less than 5, less than 3%. But when we watch over time and we then retest tumor DNA samples in the blood from patients who have had a couple of years, for example, of endocrine therapy with an aromatase inhibitor, you start to see the frequency of these mutations increasing substantially, up to about 25 to 40% of patients. This is a way that the cancer can find its way around the treatment. These mutations allow the estrogen receptor to be turned on regardless of whether estrogen is present, and that causes the therapy to stop working. So there's been a big need in metastatic breast cancer to develop newer, better endocrine therapies that can work in the setting of some of these types of mutations. And that's really important because we want to avoid using potentially more toxic treatments like IV chemotherapy. And some of these newer drugs, these next generation oral anti-estrogen drugs, have already been shown to be particularly effective in the patients that have developed the ESR1 mutation. So with that in mind, the SERENA-6 study was a really interesting study where they took a large number of patients, over 3,000 patients, who had first-line therapy with an aromatase inhibitor and a CDK inhibitor. So for example, anastrozole with ribociclib or palbociclib, which is the standard treatment. So they were following these patients with blood tests every 2 to 3 months, looking for the development of that ESR1 mutation in real time, rather than waiting for clinical progression or for radiographic progression. And if they found that ESR1 mutation, they then checked the scan. And if the patient had no signs of any progression yet on the scan, but they had the ESR1 starting to rise up kind of in secret, they were randomized. Half the patients continued their current therapy, which is what would be happening now in the real world, and half the patients switched to a new oral anti-estrogen medicine called camizestrant, and the CDK inhibitor was continued. And the concept here was, what if we catch that ESR1 mutation right when it appears, right as it develops? So if we can use these amazingly sensitive blood-based circulating tumor DNA monitoring assays and identify these very small populations of cancer cells that are starting to break through treatment and personalize the therapy to prevent that, we can hopefully keep patients on less toxic, more tolerable treatments for longer periods of time, improving, hopefully, both their quality of life and their survival. The preliminary outcome from the study that we saw just at ASCO a couple of months ago suggested that the patients who switched got a benefit on the order of approximately 7 months. If you looked at the patients who stayed on their current therapy versus the patients who switched, it was more than a 6-month improvement in time on drug. There was also a very significant improvement in what they measure as time to deterioration in quality of life, meaning the patients who switched early felt better for longer, more than a year, in terms of the deterioration in quality of life if they switched onto the newer drug. So this is really exciting data, but we need to see a little bit more. We need to see what happens to the overall survival of that cohort. We need to see what happens to those patients in the second and third line after they switch to this newer drug, because we don't know much about how resistance develops to these newer next generation oral antiestrogens. So it was a really exciting study. It was a positive study. It seemed to provoke potentially really meaningful improvements in quality of life and symptom burden, and also in control of disease for these patients. So I think we, as an oncology community, those of us who treat breast cancer, as well as any oncologist who treats solid tumors, can look at this study and be excited about the future deployment of these circulating tumor DNA sequencing technologies to both monitor the state of disease and allow us to make informed personal therapeutic decisions. And so I think the opportunities here are endless, not just for breast cancer, but across other tumor types as well.
If you want a refresher on the different types of hormone therapies, or if you want to learn more about how ESR1 mutations impact metastatic breast cancer, check out the videos linked below. SERENA-6 wasn't the only trial utilizing ctDNA presented at this year's ASCO meeting. Dr. Cobain discussed the very early findings of 2 additional trials aimed at testing how we might be able to use ctDNA in early-stage breast cancer. The DARE trial enrolled patients with early-stage hormone receptor-positive HER2-negative breast cancer that had a high risk of recurrence who were on an adjuvant hormone therapy, such as an aromatase inhibitor or tamoxifen. Patients were monitored with ctDNA blood testing every 6 months. If ctDNA was detected in the blood, but there was no evidence of cancer in the body on imaging, patients were randomly assigned to stay on the hormone therapy that they were already on, or they were switched to a more potent hormone therapy called fulvestrant, plus a CDK4/6 inhibitor called palbociclib. Dr. Cobain discussed these results.
Now, when this trial was presented, these preliminary results at the ASCO meeting, we didn't see, the long-term clinical follow-up data, but we did get a glimpse into the circulating tumor DNA data. And I want to just highlight a couple of conclusions that the authors made that I think are exciting and important. One of them was, if patients did not have detectable circulating tumor DNA throughout their surveillance and follow-up, they had an exceptionally low likelihood of cancer recurrence. So another way to say that is that if the ctDNA tests are serially negative over many, many months, if not years, many of those patients go on to have an excellent prognosis and an excellent outcome. The second conclusion, which gives us a little hint into the long-term follow-up or potential outcome for these patients, is that those patients who were positive for circulating tumor DNA and were randomized to the treatment arm that was fulvestrant and palbociclib, so switching their anti-estrogen therapy and adding a CDK4/6 inhibitor, they had a greater likelihood of what we call ctDNA clearance, than if they remained on their standard anti-estrogen therapy. So they had a greater likelihood of seeing that ctDNA level go back to undetectable, which may give us a hint that treating a patient who has positive ctDNA in a different manner could potentially change the course of their disease. But again, I want to caution that until we see the longer term follow-up over many years of these patients, we do not yet know for sure that monitoring ctDNA or switching therapy in response to ctDNA should be adopted or improves patient outcomes. We don't know that it helps patients live longer, and we don't know definitively that it actually decreases the risk of breast cancer recurrence.
The PREDICT DNA trial enrolled patients with early-stage triple-negative or HER2-positive breast cancer that were undergoing neoadjuvant systemic treatment, which included chemotherapy or a targeted therapy before surgery. In the current standard of care for patients undergoing systemic treatment before surgery, prognosis is driven by a measure called pathologic complete response, or PCR, at the time of surgery. In other words, if no cancer is detected at surgery, patients are said to have a pathologic complete response. And this is a good prognostic sign that those patients are at a lower risk of having a future recurrence. In this trial, patient ctDNA was monitored throughout treatment, prior to, and following surgery to determine if it could be used to predict if someone has no evidence of disease or needs additional treatment. Dr. Cobain provided more insight on this trial.
One of the things that the PREDICT DNA study helped us understand was that it may be that regardless of having a pathologic complete response, the circulating tumor DNA being negative or undetectable just before surgery may in fact actually be a better predictor of long-term outcome than the presence or absence of cancer remaining in the breast or the lymph nodes at the time of surgery. So again, this is preliminary data. I think there is longer term follow-up data that needs to be collected in the context of this trial. But the preliminary evidence suggests to us that circulating tumor DNA being negative prior to the patient going to the operating room was actually highly predictive of a very, very good long-term outcome.
You can learn more about this and other highlights from ASCO 2025 in the video linked below. While this preliminary data indicates that ctDNA could be used in the clinic to predict prognosis in early-stage breast cancers, researchers still need to gather that long-term follow-up data. So, what advice can we give to individuals that want to have ctDNA testing done? Dr. Cobain provided us with this valuable insight.
So for patients with stage 4 breast cancer that are inquiring about ctDNA testing, I tell them really the way in which it is most useful, and I would fully endorse, using the testing, is understanding what the next most appropriate treatment may be. I think for patients with early stage breast cancer, we can order these tests. But part of the reason that I actually currently caution patients about using ctDNA testing in early stage breast cancer is that at the moment, if the ctDNA test is positive, I do not have something that I can do, at least within standard of care, about that positive result in order to change treatment. And always as clinicians, when we order a test, we want to know that that test is going to inform something that we can do to improve the lives of our patients. And if we don't have good evidence that that's the case, then the test doesn't quite have a role yet. I think we're getting closer to the test having a role, but in early stage breast cancer, I am not routinely recommending circulating tumor DNA monitoring until I see some additional data.
Thank you all so much for watching. We hope that you're better acquainted with ctDNA and liquid biopsies, and that you feel more confident in discussing the use of these tests with your doctor. We look forward to keeping you updated on future developments in ctDNA use in breast cancer care. Don't forget to sign up for reminders for breast cancer breakthroughs. We've linked the homepage below. Please feel free to like and subscribe to this channel to catch more episodes. And finally, if you enjoyed today's episode, please take 2 minutes to fill out our short survey linked in the description below.